All right, we'll get started promptly at 8 a.m. Hi, everyone. By way of introduction, I am Dr. Jennifer Pekarsik. I'm the Chief of Pediatric Pathology here at the hospital and head of laboratories. And it's a real honor today to have with us Dr. Laura Finn, who's a professor of pathology and lab medicine at the University of Pennsylvania and pediatric pathologist at the Children's Hospital of Philadelphia, where she's the director of histology and cytopath. And throughout her long career, mostly at Seattle Children's as the AP director there, she was also a force throughout pediatric pathology. She served on the board of directors, was the president of the Society for Pediatric Pathology, and she's really led the society and throughout pediatric pathology with her wisdom, leadership, and voice of reason many of times. She also is very involved in trainee education for pathology. She actually sat for over a decade on the American Board of Pathology Test Development and Advisory Committee and is heavily involved in trainee education, which she even admits is occasionally fun. This is a homecoming of sorts for Dr. Finn in that she started her early pathology training here in Pittsburgh before some of you were born. And she was both a APCP resident. She did a dedicated chief year when there was a separate chief year, and then a 2-year pediatric pathology fellowship when it was 2 years. So we're really honored to have Dr. Finn with us today for the annual Fetterman Memorial Lecture, which honors the remarkable legacy and contributions of Dr. George Fetterman. Now, I normally give a little blurb about Dr. Fetterman and who he is, but this is actually a historic year. We're celebrating our 100th anniversary of pediatric pathology here at Children's. So this is what the whole lecture is going to be about. So I'm going to let Dr. Finn take us through this historical journey as we reflect on this leadership and scientific achievements here at Pittsburgh that has really helped shape pediatric care, not only here locally, but throughout the world with an enduring impact. So without any further ado, I give the floor over to Dr. Finn.
Well, thank you for that kind introduction. It's a pleasure to be here. In recognition of the contributions of Dr. George Fetterman to the Children's Hospital and to the University of Pittsburgh Medical School, colleagues at the university, colleagues and friends created this endowed chair or an endowed fund for this lecture in 1979, intended for a lectureship in pediatric pathology. And this year, it's my privilege to use the memorial lecture to honor 100 years of pediatric pathology at Children's Hospital and to share highlights of some of the remarkable faculty and just some of their contributions to medicine. Firstly, Dr. George Fetterman was born in Pennsylvania in 1908, and he did his undergraduate in medical school at the University of Pittsburgh, eventually joining the faculty in the mid-30s, and he became the lab director at the Children's Hospital in 1950. One of Fetterman's most lasting contributions was the 1965 creation of a society that was devoted to the practice of pediatric laboratory medicine. And the following year, he became its first president. The Pediatric Pathology Club, as it was initially called, was transformed from a group of 35 to a society for pediatric pathology that contains over 800 members from North America and beyond. It has an annual meeting, it has its own journal, Pediatric Developmental Pathology, and it provides education and networking opportunities year-round. But before George, there was Maud, where it all started 100 years ago. This is the first chief of pediatric pathology at Children's Hospital of Pittsburgh, Dr. Maud Menton, who was born in Ontario, Canada in 1987. She received her BA and master's degree from the University of Toronto, then completed her medical school in 1911, joining the first class that allowed women to attend. Despite being one of the first female Canadian physicians, she was unable to obtain a research position, and that resulted in her traveling across the country into different labs and different institutions. So she eventually earned her PhD from the University of Chicago in biochemistry in 1916. Her first job as a pathologist was at the McGee Women's Hospital, and then she was hired as a demonstrator in pathology at the Pittsburgh School of Medicine in 1918, whereupon she became the pathology director at Children's Hospital in 1926. So I'm sure most of you recognize this equation, but I think most of you probably don't recognize this equation. But there's a hint at the bottom, just in case. So yes, she is that Menton of the famous Michaelis-Menten equation. Okay? So in 1913, excuse me, she joined a German biochemist named Leonore Michaelis, and together they derived this landmark mathematical model that has become the foundation of modern enzymology and actually marked the beginning of modern biochemistry. The equation is an essential tool in the development of vaccines and in medicines, and remains a key analysis in biochemical and medical laboratories around the world. Here's that actual first publication, and it's worth noticing the title. The use of Miss at that time was applied to assistants and those without formal credentials. But in 1913, Dr. Menton was already a physician. And the indignities continued throughout her illustrious career, as exemplified here in this award from the Medical Society of Pennsylvania, acknowledging 50 years of service. It's probably a template. But Dr. Menton didn't let ignorance or obstruction or prejudice block her progress or her curiosity. Her research genius and passion for teaching sustained her career and led to several other discoveries. So I'd like to talk about just two of those discoveries today because they focus primarily on the pathology lab. In 1944, she and collaborators published a method that allowed visualization of alkaline phosphatase in tissue, initially focused on the kidney. The method allows exact spatial distribution of enzyme by creating an insoluble dye at the site of the enzyme reaction. This may not seem very earth-shattering, but it basically created the field of enzyme histochemistry, a technique that is still widely utilized in the pathology laboratory today. For example, it's been used to determine leukemia lineage. Any muscle biopsy gets a workup with histochemical analysis. And here you can see it's used to show abnormal intestinal brush border of microvillus inclusion disease. So helpful in the diagnosis of congenital diarrhea syndrome. In 1944, Dr. Linus Pauling used electrophoresis to distinguish hemoglobin variants while studying sickle cell disease. And although he is famously credited for being the first to do so, Dr. Menton actually did it 5 years before. She clearly showed that fetal and adult hemoglobin had different physical properties. And she postulated that there's likely multiple different types of hemoglobin, which we now know to be true. Her study pioneered this method of separating proteins, which is still used today in some variation. So it turns out that Dr. Menton actually taught Dr. Fetterman when he was in medical school. And later, as a young pathologist, she co-authored his first publication about coronary sclerosis in infancy, a rare and usually fatal disorder associated with extensive calcification of medium and large arteries. Although the cause was unknown, they suggested that it had a familial relationship for the disease. And it turns out they were right. It now goes by the name generalized arterial calcification of infancy, and it's known to be associated with biallelic variants in these genes, which regulate bone mineralization and prevent soft tissue calcification. New imaging modalities and molecular testing allow for a diagnosis before an autopsy. And these emergent treatments considerations that can restore metabolic pathways. So I'd say that's not too shabby for one's first publication. Dr. Fetterman succeeded Dr. Menton as the chief of pediatric pathology after her retirement in 1950. He's also widely credited for the use of urine cytology to identify cytomegalovirus inclusion, shifting the detection from a post-mortem pathologic diagnosis to a pre-mortem clinical diagnosis, proving that CMV-infected renal tubular cells shed very heavily into the urine served as a foundation for modern screening and established urine as the gold standard specimen to detect congenital CMV. It is still true today, with the addition of culture and PCR supplementing the highly cost-effective microscopic exam. Dr. Fetterman became a leading expert in this meticulous technique of kidney microdissection to physically isolate a nephron. And through this, he revolutionized pediatric nephrology, proving how the human kidney grows, matures, and fails. Here's just one example of his work. The symptoms of Fanconi syndrome suggested that there was a defect in the proximal tubules in cystinosis, where it was shown to be shorter and actually have a very narrow neck where the tube extends and connects to the glomerulus. This defect became known as the Swan Neck deformity. This Swan Neck deformity is actually not restricted to cystinosis, but is evident in other causes of Fanconi syndrome. But at the time, they weren't sure whether this was an acquired disease or a congenital disease, so whether it was primary or secondary. So Dr. Fetterman proved which it was. He studied patients with cystinosis at different age and showed that as crystals accumulate in the proximal tubules, these symptoms increased and the acquisition of the Swan Neck lesion was seen with age, proving that it was an acquired, not a congenital defect. So cystinosis, we now know, is an autosomal recessive lysosomal storage disorder that leads to kidney failure by about 10 years of age. And it accounts for about 2% of pediatric transplant recipients in the US. The affected gene, CTNS, encodes cystinosis, which normally exports cysteine out of lysosomes. But when it's deficient, the accumulation of cysteine in lysosomes cause activation of the mTOR pathway, which leads to proximal tubular dysfunction and actually dedifferentiation of the epithelial cells, basically flattening of the cells, which accounts, excuse me, for the flattened epithelium of the Swan Neck lesion. Eventually, the tubule completely separates from the collecting system. So the glomerulus and the collecting system no longer attach. This is the so-called aglomerular tubulus. And this leads to lack of filtration and eventual kidney failure. I like to believe that Dr. Fetterman contributed to some of this understanding. His kidney microdissection study revolutionized the pediatric nephrology, providing the first 3D structural understanding of how normal and diseased nephrons change. Here you can see the normal growth change with time. It's as the kidney develops in an infant, how it changes with ischemia, how there are changes in congenital nephrotic syndrome, and how it changes when cysts develop. But Dr. Fetterman's interest extended beyond the kidney. In this seminal review in 1963, he detailed 18 pediatric autopsy cases of polyarteritis nodosa. Fetterman and Roberts concluded that this usually lethal vasculitis of the coronary arteries appeared consistent with a rather constant clinical syndrome, basically something that recurred. And the symptoms include fever, rash, and conjunctivitis. They renamed it polyarteritis of infancy to distinguish it from the adult disease. Then 4 years later, after having spent time in Pittsburgh with Dr. Fetterman, Dr. Kawasaki proposed a new disease that he entitled mucocutaneous lymph node syndrome. Rather than fatal, it was a self-limited disease, but presented with similar symptoms as polyarteritis and resulted in coronary artery vasculitis that led to aneurysms. In 1977, the famed pathologist, Dr. Ben Landing, compared the pathology cases of American, continental US polyarteritis nodosa with those of mucocutaneous lymph node syndrome in patients from Hawaii and Japan, and he found that there was no pathologic difference, thus concluding that they were probably the same disease. And then today we know that Kawasaki disease is actually recognized for its varied presentation. Early diagnosis and prevention, early diagnosis and intervention can prevent fatalities, but nonetheless, it's the leading cause of acquired heart disease in developed countries. The trigger remains unknown, but evidence suggests that the pathogenesis relies on some genetic defect or genetic predisposition to abnormal immune responses. Maybe Dr. Fetterman was onto something. But Dr. Fetterman wasn't the only person who was interested in hearts at the Children's Hospital. So was his successor, Dr. Frank Sherman. By all accounts, Dr. Sherman was a generous and affable man who focused on being a doctor since he was a child. He liked to understand the root of problems, hence his calling for pathology. He was a Pitt graduate and became a volunteer faculty at the University of Pittsburgh in 1943, entered the pathology at the Children's Hospital under Dr. Fetterman in 1954, and that year he started collecting and classifying autopsy hearts. In his words, he was motivated by the personal desire to learn the morphology of congenitally malformed hearts. And as the collection grew, it developed a stature of a museum, which piqued the interest of Children's Hospital cardiologists and surgeons, and of clinicians from afar. Others with an interest would travel to study the collection, including famed cardiologist Dr. Helen Taussig of the Blalock-Taussig shunt. In 1963, when the museum had over 500 samples, Dr. Fetterman published this atlas so that the collection could be studied beyond the building. And it was more than an atlas. It was a book that guided in the novel approach of examining the heart in situ. And this allowed mapping of the venous system connections and the correlation with radiology shadows, with EKGs, and even with a surgical approach. The museum continued to grow, and today, named after Dr. Sherman and Cora Lennox, maybe people here remember her famous cardiologist from Children's Hospital. The museum now is housed in the Department of Pathology and contains nearly 3,000 specimens, and it continues to be utilized for education, therefore patient care. Like the atlas, the museum hearts are used both within the department and beyond children's. For example, at a recent master class in cardiac morphology directed by members of the Children's Heart Institution and visiting scholars like Dr. Robert Anderson from London, it was used to demonstrate the malformations of the collection's anomalies. And the demonstrations were performed by former CHP pathology assistants, the one in the room, Mr. Bill Devine and Diane Spencer. So I'd say, well done, Dr. Sherman. That's quite a legacy. Frank Sherman chose fishing over administration, and he retired to Florida in 1977, replaced by his former colleague, Dr. Ed Eunice. So Dr. Eunice was a man of many looks. Here in the 1960s, and here in the 1970s, and here in the 1990s. And I'm not showing these pictures as a commentary on his fashion sense, but to highlight how he had the ability to progress with the times. So, but back in the day of black and white, electron microscopy was the modern diagnostic tool, and it was crucial for the definitive diagnosis of viruses, of metabolic diseases, and of neoplasms. In 1978, Dr. Yunus published this foundational work that provides a comprehensive guide for the identification of viral agents with detailed instructions on the lift technique that he refined, whereby atypical or suspicious cells can be actually lifted off the glass side and then subject to ultrastructural examination. This technique is still used today in highly skilled electron microscopy departments. In 1970, Dr. Yunus pivoted to mastering Hirschsprung's disease after the invention of the suction biopsy gun. I'm sure everyone in the audience is familiar with Hirschsprung's disease, which is an aberrancy or a defect in the migration of neural crest cells to the distal colon. The reliability, or the Hirschsprung's disease today can reliably diagnose by suction rectal biopsy, but at the time, it needed to be validated in the infancy of the suction biopsy gun. And so Dr. Yunus and Sherman were instrumental in proving this efficiency. So the pediatric pathologist, to make a diagnosis of Hirschsprung's disease, looks at 75 to 100 sections of rectal tissue, proving the presence or the absence, actually not seen, any ganglion cells. So think about that. We're making a diagnosis by not seeing something. So wouldn't it be better to make a diagnosis by finding something present? Remember when I talked about Maud Menton, she essentially invented histochemistry? Well, this is another example of its use. Acetylcholinesterase is a methodology that's invaluable contributions were made of its use were made by Dr. Yunus. And it showed the utility of adding a positive finding to diagnose Hirschsprung disease. The acetylcholinesterase in the Hirschsprung patient marks these enlarged and increased numbers of nerve fibers, which are absent in the colon, in the normal colon. And this approach is also still used today. As technology advanced, so did Dr. Yunus, applying what was then the new technique of fluorescence in situ hybridization to disaggregated paraffin sections. Dr. Yunus and his former fellow, Deb Schofield, along with Boston colleagues, showed that a cellular mesoplastic nephroma, which is a low-grade invasive spindle cell tumor of the kidney, and an infantile fibrosarcoma, which is another low-grade invasive spindle cell tumor of soft tissue, had copy number gains in the same chromosomes, perhaps suggesting some link between the tumors. But now we know that both tumors are commonly associated with ETV6 and TRK fusions, and maybe this idea was instigated by this paper. These tumors are both equally responsive to NTRK therapies. And then this man came along, Dr. Tom Starzl, who in 1981 performed the first pediatric liver transplant in Pittsburgh, which transformed pathology and gave it a new focus. Pittsburgh became the transplant capital of the world. So adapting to the times, Dr. Yunus, along with his successor, Dr. Jaffe, and often in collaboration with pathologists at UPMC, played a pivotal role in pioneering the transplant program, helping to establish diagnostic guidelines for the complications of liver transplantation and of small bowel transplantation, followed by multivisceral transplantation. So transplantation, especially the liver, consumed everyone at Pittsburgh, and the Children's Hospital became a repository for unusual liver diseases. Speaking of unusual, some in the audience, I see Dr. Horsland laughing, might recognize Dr. Alex Knisely. Others may remember him too. Alex became interested in Byler's disease because of liver transplantation, which offered a new treatment, and because of the material the transplants provided for study. Byler's disease at the time was recognized as a progressive intrahepatic cholestatic syndrome that was often fatal and involved Amish children who were descendants of Jacob Byler. It was known to be transmitted in an autosomal recessive manner, and obligate carriers had elevated liver function abnormalities. By light microscopy, there was canalicular bile plugs without inflammation, and by electron microscopy, the canaliculi lacked microvilli and contained this coarse granular bile. The term progressive familial intrahepatic cholestasis, PFIC for short, became loosely synonymous with Byler's disease. The patients had comparatively low gamma GGT for the degree of cholestasis, and they also had elevated serum bile acids. The Pittsburgh team became experts, and they and others recognized that PFIC was not a single entity, that it differed in its phenotype and its pathology. So some cases, unlike that seen in the Byler descendants, had pathology that showed giant cell hepatitis, and their canaliculi by electron microscopy contained bile with very small granules, unlike the coarse granulars of bile syndrome. This was then called, unlike the coarse granules of Byler's disease. So therefore, this entity was considered Byler's syndrome, which was then referred to as PFIC2. By comparing the early biopsies with the explanted livers, the pathologists at CHP became leading experts in the diagnosis. So during the same period, Dr. Knisley was becoming an uncle multiple times over and regularly commissioned crib quilts for his newly arrived nieces and nephews. So along the way, he met a few women, coincidentally from Northwest Pennsylvania, who sewed for money, and they just happened to be named Byler. These seamstresses introduced him to affected family members, and Alex, who was not only inquisitive and eccentric, but also a polyglot, was, in his words, off to the races. With a CHP phlebotomist in tow, Dr. Knisley made home visits to collect blood from the Amish kindred, sharing information with caregivers, all before the pre-HIPAA era. After one day of a visit, the father of the first Amish patient to undergo a liver transplant escorted Alex to his car and remarked, "Thank you for taking an interest." So the material that was garnered by Dr. Knisley contributed to discoveries in PFIC disease, including the definitive separation of PFIC1 and PFIC2, Byler's type and non-Byler's type disorders, by allowing the positional cloning of the Byler's disease to chromosome 18, and led to identification of the PFIC locus on chromosome 2, and eventual identification of the PFIC gene, BSEP, which is a bile salt export pump that's located on the canalicular membrane. Historically, PFIC nosology was anchored in the clinical phenotype in the biochemical features, but high throughput sequencing has redefined the landscape. Today, Omen recognizes 13 distinct types of PFIC, each driven by mutations in specific genes that are related to essentially pump failure at the canalicular membrane, to defects in tight junction integrity, in defects in vesicular trafficking, and in nuclear receptor signaling. And undoubtedly, this list of genes will grow. So as you can see, there was a lot of pivoting and discovering during the Eunice years, who encouraged and allowed others to excel. Dr. Eunice was known for his sharp eye among pathologists in Pittsburgh, and his microscope was open to all for informal consultations. His successor, Ron Jaffe, said, "Those of us who worked and trained with Ed Yunus knew him as a deeply engaged human being and one of the finest pathologists ever." That's quite a compliment coming from another of the finest pathologists ever. Many of you may know the fine pathologist, Dr. Ron Jaffe, who officially led the department for 10 years, but whose leadership was felt long before and long after the chief sign hung on the door. Dr. Jaffe joined the department in the 70s and was known as an exceptional pathologist. He authored nearly 250 publications, and he delivered multitude of national and international lectures and seminars. Dr. Jaffe, along with his UPMC colleagues, contributed these, among many other seminal works that define the pathology of liver, of small intestinal, and of multivisceral transplantation. His work included remarkable observation and recommendations for the detections of opportunistic infections in immunocompromised patients, including better sensitivity of the early CMV antigen immunostain over DNA hybridization and culture, the unique appearance of adenovirus in allografts, which when missed can lead to potential fatalities, and the first report of adenovirus infection of the biliary tree in humans. He published widely on issues related to EBV, including the pathology of PTLD and its early detection with EBV RNA, an EBR stain, which is still a standard procedure today. And of course, he and others were the first to publish the EBV smooth muscle tumors in transplant patients. And the list goes on and on. Jake Dimitris, internationally recognized expert transplant pathologist and frequent co-author, summarized Dr. Jaffe's contributions. I'll read it. "Ron was critical to our co-publications of human allograft rejection, graciously allowing me to drive while contributing cases and crucial guidance. However, it's our shared interest in dendritic cells and antigen-presenting cells that persists with me until today. Well into my career, I continue to reach out for Ron for his opinion and advice on important topics, and I'm grateful for his essential impact that he made on my career and my life." Dr. Jaffe's interest and expertise in dendritic cells is also recognized around the world. A particular contribution he made related to the diagnosis of Langerhans cell histiocytosis. Historically, Langerhans cell was confirmed by the identification of these characteristic structures, Birbeck granules, in the Langerhans cells by electron microscopy. In 1985, Dr. Jaffe changed that diagnostic algorithm by proving the sensitivity and specificity of these two immunostains, CD1A and S100, for Langerhans cells, thus eliminating the need for electron microscopy. Later, he showed the utility of Fasken and Langerin and showed its staining in normal and abnormal tissues, but he validated what is a current standard approach to diagnosis of Langerhans cell disease. Using PCR and capillary electrophoresis, he showed statistically differences. He identified statistically significant loss of heterozygosity in both multi-system disease and special site high-risk disease compared to single site and low-risk Langerhans cell disease, supporting the at the time novel theory that Langerhans cell histiocytosis was a neoplastic process, and providing insight into the molecular evidence of disease progression. He also was one of the first investigators to publish a large series of patients with histiocytic lesions that developed after acute lymphoblastic leukemia. These lesions varied in their morphology from atypical JXGs to Roside-Dorfman disease to LCH to histiocytic sarcomas, but they all had the same molecular signature as the original leukemia. These findings suggested a common precursor or transdifferentiation, basically lineage switching, or both. With his friend Blaise Favera, Dr. Jaffe showed the coexistence of macrophage activation syndrome, that it was not as rare as once thought, and it was likely underdiagnosed. It occurred most frequently in young patients with multi-system disease, and it had a poor prognosis. They proposed that the inflammatory cells of the LCH lesion produced cytokines that entered the bloodstream and influenced hemophagocytosis and macrophage activation systemically. And it's now understood that the clonal histiocytes activate hyperinflammatory and fibrotic pathways, leading to long-term consequences. So in summary, Dr. Jaffe was passionate about pathology and made keen observation that advanced the field. And I could move on from Ron with this picture, official one that's in the CHP archives. But I think he would prefer this one that includes a microscope, because those of us who knew him know that his favorite thing was to sit at the scope and commune with the slides. That's what his words, commune with the slides, and I quote him all the time. Dr. Miguel Reyes arrived in 2008 from Yale University and served as chief until 2024. He's very active in the Pediatric Pathology Society and its sister societies around the globe, and has an academic focus on neural crest disorders and testicular pathology. He trained some of their current faculty. I think Dr. Pekarsik was one of his trainees, and he is now the chief pediatric and perinatal pathologist at the division of the University of Miami at the Miller School of Medicine. And this is our current chief, Dr. Jennifer Pekarsik. I think I can speak for her and say that she sees her job is to carry on the legacy of Dr. Ron Jaffe, striving to inspire and mentor future pathologists and make discovery in histiocytic disorders, to build a department of excellence that rivals his more than 4 decades of contributions. I was but a link in the chain, Dr. Jaffe's own words, that were delivered at the Histiocyte Society when he received its highest honor, the Golden Pin. My time was the immunohistochemical era, he said. The future lies in decoding biologic and molecular information within the tissue. And he passed that task on to his colleague, Dr. Pekarsik. And Dr. Pekarsik willingly accepted the baton and is off and running. She became a recognized expert in histiocytic disorders, and her work centers on international consensus building that has shaped tumor classification, pathologic and molecular diagnosis, here with Erdheim-Chester disease, and here with Reside-Dorfman disease. Speaking of lineage switching, for those who were paying attention, I thought this article was actually pretty interesting. She and her colleagues showed that at diagnosis, BRAF mutations are detectable in cellular DNA from mononuclear cells and myeloid cells, here in the orange, but not in T cells from those patients with high-risk LCH, and that the variants decline with treatment as the disease activity decreases. They can persist at a low level, and this was presumed to be in the myeloid cell compartment. However, the study showed that after years of treatment, persistent BRAF mutations actually were detected, but the reservoir had unexpectedly switched from the myeloid cells, where they dropped, to the T cells. So these results are really interesting because they may affect how monitoring strategies are used and affect the potential withdrawal of inhibitor treatment. I know Dr. Jaffe would be very proud of all the molecular testing that Dr. Pekarsik is using. She recently published the largest series of ALK-positive histiocytic neoplasm, helping to find 3 distinct clinical phenotypic groups and characterize the pathology of this emerging entity. They range from classic xanthogranuloma with Teuton giant cells to those that have a spindle cell appearance even to those with dense mononuclear cell infiltrate. For this effort, Dr. Pekarsik was awarded the Lottie Strauss Prize for meritorious work for individuals under 40 from the Society of Pediatric Pathology. Remember that? That's the one that Dr. Fetterman created 60 years ago. So it seems we've come full circle. So now you see it, you've seen it, the tour of the accomplishments of the Children's Hospital Pathology Department and its chief over the last 100 years. It's a pretty impressive lineup, but do you actually see it? Just look at the names. Do you see it? Now do you see it? Maybe this will help you see it. It's literally a man sandwich. As you'll know, Dr. Menton and Dr. Pekarsik have a lot in common. They're curious, they have tenacity, they promote women, but fortunately, they've encountered different men along the way. And here's one of the supportive men sitting in our audience, along with its growing faculty at the department, who undoubtedly will continue the excellence and contributions of CHP pathology to the care of children in the region and beyond, maybe to infinity. But it goes without saying that it takes a village, and the pathology department is only as good as its people. So congratulations to everyone, the faculty and staff at CHP Pathology. I wish you many future successes.